Welcome back, ladies and gentlemen. This is Dr. Robert Feldman, board-certified neurosurgeon for over 25 years, talking to you on the Yourgotodoc YouTube channel, where we talk about all problems neurosurgical. And today we're going to be talking about pinched nerves in the neck, otherwise known as cervical radiculopathy. Cervical means neck, radiculopathy means pinched nerve. So that's what we'll be talking about today. Typically, this comes from a herniated disc or a bone spur. It'll give you pain, numbness, and tingling going down the arm in whatever distribution that particular nerve goes down the arm. And sometimes, if you're not lucky, it'll also be weakness. So let's get right to it. Pinched nerve in the neck. So what's the typical story? The typical story is one day you're working in the yard, you're hanging some drywall, you're hanging a ceiling fan, everything seems fine. You go to sleep. The next morning, you wake up with a crick in your neck, otherwise known as pain in the neck. Typically, this is a tight muscle type feeling. And then either right away or by the end of the day, your arm's starting to ache. Either pain, numbness, and tingling, or just sometimes pain to begin with. Symptoms don't get better. You see your primary care doctor, your pain management doctor, your chiropractor. They get some x-rays, which show a little bit of arthritis, but otherwise don't look too bad. The symptoms persist, despite pain medicine, muscle relaxants, anti-inflammatories like Motrin or ibuprofen. And then eventually you get an MRI, and lo and behold, the radiologist reads your MRI and says, you have a pinched number 5 nerve, or number 6 nerve, or number 7 nerve. Your primary care doctor's office calls you and says, you've got a pinched nerve. We're going to send you to see your neurosurgeon. And you're waiting for that appointment, and you Google searched pinched nerve in the neck, and you found this video. So that's kind of the typical story on how most of you probably got here. So how does that nerve get pinched, and why did it happen the way it does? So in a little bit, I'm going to be showing you some diagrams and some MRI pictures showing what it looks like when these nerves get pinched. But let's take a look first on a model of what that looks like. So on this little spine model here, we can see, let's say this is the front view of the number 5 bone, number 6 bone. This is the 5-6 disc in between the two bones. Don't think of this disc as this flat thing that slides in and out. Think of it like a shock absorber or a pocket of jelly. And the stuff inside the shock absorber can escape out. If we turn to this side, we can see right in the corner here, the disc looks pretty good. The nerve does not look pinched. In this case, if this were the 5 bone and this were the 6 bone, this would be considered the number 6 nerve. But if we look on this side, we see this red ball thing right there. And that is an example of what it would look like if a piece of the jelly from inside the shock absorber escaped out and is now pinching the number 6 nerve. And this is pretty much what a herniated disc looks like when it's pinching a nerve. Now, at the same time, instead of this being a piece of disc, you could imagine that this bone on the edge here has a bone spur growing on it. And then this nerve would be resting right on that bone spur. So if we looked on this side, right there would be a bone spur that could pinch that nerve. And you could also get a bone spur growing off of these little joints back here, and that would also pinch the nerve right there. So lots of spots where bone spurs can grow to pinch nerves, but typically one spot where a herniated disc will pinch a nerve. And this is what it would look like on a model of a pinched nerve in the neck. So let's take a look at some diagrams of the cervical spine. And if we look over here on the left, this is a side view of the cervical spine. So we're looking from right to left here, and these squares are the bones of the spine, the vertebral bodies. These squares, this square, this square. The stripe in between is the disc, the shock absorber, the pocket of jelly. Here you can see that piece of disc squeezing out, similar to what I showed you on the model. And then here is the nerve getting pinched by that piece of disc. This picture in the middle here is a sort of down the tube view of the cervical spine. The spinal cord is in the middle here. The yellow stringy things coming out on either side are the nerves. The center silver area is the disc, and this sort of spongy looking stuff squeezing out to the side is the herniated disc that's pushing on the nerve root. This picture on the right is an example of a more centralized herniated disc, similar to the picture we just looked at. In this case, the nerve root is not being pinched by the herniated disc, but the spinal cord is. And this would give you different symptoms. Instead of the symptoms shooting down your arm, you could get symptoms of problems in both of the arms, both of the legs. The fibers that go to the legs run through here, as well as possibly bowel or bladder symptoms, and potentially a lot more neck pain here compared to a pinched nerve pain, but less arm symptoms with a centralized disc herniation like this. And this is a good segue into the next picture we're going to be looking at. Here's an example of a bone spur growing on the bone, the vertebral body, causing a pinched nerve here. And then here's an example of a bone spur growing on the facet joint, which is in the back part of the spine. And that bone spur would be pinching the nerve on the back part of the nerve. These bone spurs grow because the disc is not functioning well, the bones are rubbing around too much because that shock absorber is not doing a good job, and bones are living things, they respond to pressure and forces. So if there's excess pressure and forces being applied to these bones and these joints, they will grow bone spurs in order to increase surface area, which in turn is an attempt to decrease movement. So ultimately, the excess movement caused by this bad disc leads to the ultimate formation of these bone spurs, which can pinch the nerve in this passageway here, which is called the foramen. Bone spur here pinching the front part of the nerve, bone spur here pinching the back part of the nerve, herniated disc here pinching the spinal cord, herniated disc here pinching the nerve, herniated disc here pinching the nerve, just from a different viewpoint. And these are diagrams that show herniated discs and bone spurs. Let's move on to some more diagrams to try and explain this even more. So here are a couple more diagrams showing bone spurs and not herniated discs. So here you can see these vertebral bodies or blocks of bones in the neck have all these bumps on them. And these are, again, examples of bone spurs trying to increase surface area because of excessive movement. And these bone spurs in the front here aren't causing any trouble. They're not pinching any nerves. But this bone spur here, this bone spur here, these bone spurs up here, this bone spur here, these can all cause nerve pinching problems. And this is what would give you that cervical radiculopathy or pain going down the arm. This picture again on the right is another example of the bone spur pinching the nerve root. This back here is the facet joint, which is the joint between the adjacent bones in the neck. It's supposed to move around, that's what joints do, but if they move around too much, the bone spurs will grow and the nerve will get pinched. In this case, the spinal cord looks fine. So let's take a look at what a herniated disc will look like on an MRI. These are MRIs of the cervical spine, T2 images. Basically, on T2 images, anything that has a lot of water in it will be white. So if we look at this picture on the left, this is a side view of the neck. So you're looking from left to right or right to left. And this is kind of a slice right down the middle or maybe off to the left a little bit. And you can see the squares here are the bones of the neck. The stripes in between them are the discs or the shock absorbers or the pockets of jelly. And here is an example of a fairly large disc herniation. That black stuff there is the piece of disc that escaped out of here, and it's pushing on the spinal cord, and we'll see on the next picture to the right that it actually is more off to the left and less pinching the spinal cord and more pinching the nerve heading out to go to the arm. So if we take a slice through this picture here on the left, coming through an axial view or a down the barrel view or down the tube view, that would be this picture on the right. So this entire picture on the right here is a slice through this picture on the left. And on this picture on the right, we see the spinal cord here in the center. That's this circle here, which on the other picture would be right there. This black circle here is the disc, again seen end on instead of being seen from the side. And that disc right here is this disc right there. And then, of course, this big black ball here, or grayish looking ball here, is a piece of disc that escaped out of here. towards the spinal cord and the nerve, and it's slightly pushing the spinal cord here, but it's filling up this hole here. This is supposed to be an open pathway here for the nerve to go out to the arm. It's being filled up by this piece of disc, and if this were, for example, the number 6 nerve coming out between the 5 and 6 bones, like it looks like over here, that number 6 nerve would be pinched and irritated. And in the next picture, we'll be looking at about what kind of symptoms you'll have if the number 6 nerve is pinched. But this piece of disc here is this piece of disc here. And this is an example of an MRI showing a herniated disc in the cervical spine. So now let's take a look at what bone spurs look like on imaging. This picture on the left is a CAT scan, and this picture on the right is an MRI. And what you can see here is, again, a down the tube view of the cervical spine. This is the disc area, or if we went a little lower or a little higher, it would be the vertebral body area. Here's the facet joint on one side, the facet joint on the other. And this material here, which looks a lot like the bony structures around the spine, is a big bone spur, and the spinal cord is in the center here getting squished. So that's an example of what a bone spur looks like on a CAT scan. CAT scans are pretty good at looking at bones, not very good at looking at soft tissue. So you can see the spinal cord is not very well defined in here. But if we look over at the picture on the right, this is an MRI. The spinal cord is this kind of whitish, grayish looking substance here. All this black stuff is bone spur. And this is a disc from in between the two bones. So the bone spur on an MRI looks pretty dark. If it was a herniated disc, especially a relatively fresh one, this would be more gray looking than black. But this is a good example of what a CAT scan would look like with a bone spur. So when you go in to see your neurosurgeon, either an orthopedic spine surgeon or a neurosurgeon, it's not unusual to be able to figure out where the nerve is being pinched just from the story and the physical exam. Keep in mind that no matter which nerve in your neck is pinched, almost everybody's going to get neck pain from that. Oftentimes it'll be on the same side as the pinched nerve, so if it's a left-sided pinched nerve, you'll have left-sided neck pain. And keep in mind that's typically muscular, and the reason those muscles tighten up in your neck and your back is because your brain knows that your nerve's being pinched and it's trying to keep everything still back there. And it does this without your permission. It basically says we're going to tighten up all those muscles back there to keep your joints still so that that nerve does not get irritated even more. And again, it does that without your permission. Keep in mind there's a very large triangular shaped muscle in your back called the trapezius muscle, and the attachments to that muscle can sometimes go all the way down to the middle of your back. So you could have a pinched nerve way up here in number 3 or number 4, and in the middle and center of your back it's going to hurt because those muscles are tight back there. But in addition to those tight muscles in your neck, if you're pinching a nerve in your neck, you're going to get arm symptoms. And that's different than neck pain from just arthritis. Neck pain from arthritis is just your joints are rubbing around too much, you've got inflammation in there, your neck is inflamed from that, and your muscles are tight trying to keep your neck still because your joints are rubbing around too much. That is different than a cervical radiculopathy where the nerve going down your arm gets pinched. And that pain from just arthritis in your neck, I talked about in a separate video on cervical degenerative disc disease and neck pain. If you don't have arm pain and you just have neck pain, stop this video here and go back to that other video which doesn't include the arm symptoms. So getting back to the pinched nerve in the neck, it's often not hard to figure out which nerve is pinched just by how the patient describes where it hurts, where it's numb, or which muscle is weak. So for example, the number 6 nerve. If you have a pinched number 6 nerve, you're going to have specific symptoms. So I'm going to go over which nerves cause symptoms where in the arm, where you'll have numbness and tingling, which muscles will be weak, using some charts and some figures in a little bit. But just let's, for example, stick with that number 6 nerve. If a patient has a pinched number 6 nerve, they're typically going to have neck pain, paracervical pain on the sides of the neck, the shoulder area here, inside the shoulder blade. And then if it's the left-sided nerve, it's going to run down the arm over here sort of on the top and front of the bicep, the top of the forearm, radiating into these 3 fingers, or sometimes just these 2 fingers. That's typically the number 6 nerve. The number 7 nerve will go down more towards the middle of the hand and the middle of the bicep and tricep area. The number 8 nerve will be on the inside of the forearm and into these 2 fingers here, the pinky finger and the ring finger. The number 6 nerve, if it's really badly pinched and you have weakness, you're going to have probably a bicep weakness, maybe some wrist weakness. The number 7 nerve, you're going to have tricep weakness, also wrist weakness. And the number 8 nerve, you're typically going to have weakness in these little muscles in the hand here, and therefore weakness in the fingers. So those are some examples of clues that you can look for as the physician on which nerve is being pinched before you even see the pictures. And in the old days, you didn't have pictures. You'd have to basically go on the story and the physical exam. Now we've got MRIs, and you can actually confirm or prove that the symptoms you see in the exam room or the symptoms that the patient is describing matches up with the nerve that's being pinched on the MRI. And this combination of the pictures matching the symptoms dramatically improves the confidence level that that is the spot that the trouble is coming from, and therefore dramatically improves the success rate of a surgery to unpinch that particular nerve. So imaging has been a game changer on the confidence level of figuring out where the problem is and being sure that the surgery to fix it is going to fix it. So now let's take a look at what each particular nerve in the cervical spine would cause symptoms with if it were upset or pinched or irritated. Keep in mind on this chart you can see C5, 6, and 7, and 8 are shown. These are the most common nerves to be pinched in the cervical spine. I find C6 and C7 are the top 2. If we look at the pictures here, you can see C2, C3, and C4 are also listed, but these are much less common. So if you look at the C5 nerve, which comes out between the C4 and C5 bones, you'd be looking for pain shooting down the shoulder and arm into the bicep area. I find in a lot of patients this area of the shoulder that's listed as C6 shows up as C5 when you have a C5 nerve being pinched. I also would say that with C4, the upper chest area gets bothered a lot. And this just goes to show that not everybody is exactly like the textbooks or the pictures, and everybody's nervous system is not right out of the books, so you have to give a little bit of leeway on symptoms and how they present. But with the C5 nerve, you're going to get the shoulder and bicep area for pain, numbness, and tingling. You're going to get weakness in the deltoid, which is what brings the elbows up, like you're trying to flap your wings like a chicken kind of thing. And the supinator reflex, I don't often see when a C5 nerve is being pinched, but that is the associated reflex with the number 5 nerve. With the number 6 nerve, you're going to get pain down the shoulder area into the bicep and outside of the upper arm, down the top of the forearm into the thumb. I often will see the C6 nerve causing index finger pain, numbness, and tingling. And that will definitely give you a reflex loss of the bicep reflex, tapping on the reflex here. The number 7 nerve will shoot down the back of the shoulder and arm, the middle of the forearm into the first 2 fingers, sometimes the ring finger. That is associated with the tricep reflex and tricep weakness if it's really pinched. And then finally, C8 will go down the back of the lower shoulder, the bottom of the arm, the elbow, and then into the last 2 fingers. This is pretty definitive for pain, numbness, and tingling with the number 8 nerve. And if you're going to get weakness, it's going to be in all the little muscles of the hand here, causing some grip weakness. And by the way, the number 6 nerve is going to give you weakness in wrist extension, and the number 7 nerve will give you weakness in wrist flexion. So reflex loss, weakness in particular muscle groups, pain, numbness, and tingling down a certain stripe in the arm can all lead you to a hint of where or which nerve is being pinched. So if, for example, you have pain running down the arm into the thumb with numbness and tingling, and you've got bicep weakness and your bicep reflex is lost or decreased, and the MRI shows a pinch number 6 nerve from a herniated disc, you can be pretty darn confident that that's where the problem's coming from, which in turn means you can be pretty confident that if you unpinch that number 6 nerve, the patient's going to do well. One final note, you can see the C2 nerve area here. No matter which nerve is pinched in your neck, the same muscles back here will tighten up and give you neck pain. You may also get some shoulder blade pain. These muscles are tightening up to try and keep your neck still without your permission. So that really does, where your neck hurts doesn't tell you much about which nerve is being pinched. But a lot of people with pinched nerves in their neck or neck problems in general in their spine will get a lot of headaches. And the reason for that is that the C2 nerve, or the occipital nerve, will go through these muscles in the back of the neck to get to the scalp up here. If these muscles are very tight and in spasm, it can irritate the number 2 nerve, and that's why you can get these what are called occipital headaches back here from irritation of the number 2 nerve going through the muscles back here, which are in spasm. Again, not a real good hint of which nerve is being pinched, just a good hint that all these muscles are tighter than they're supposed to be. So this is a good couple of pictures to look at to try and guess which nerve is being pinched based on your symptoms. So you could look at this and study this and really think hard about your symptoms and walk into your surgeon's office and say, hey, I think my number 6 nerve is being pinched, or hey, I think my number 7 nerve is being pinched, and really impress them that you know what you're talking about. But anyway, that is a good chart for those associated symptoms with associated pinched nerves in the neck. Okay, so we've looked at pictures. We know which nerve is being pinched and why. It's either a piece of disc that I showed you on the MRI, an example of that pinching the nerve, or it could be a bone spur. I showed you that on an MRI, and a CAT scan pinching the nerve. So we now know what the problem is and where. What are your options? What can you do at this point? Well, what I'll usually tell my patients is, we know which nerve is pinched, we know why it's being pinched, it matches up with your symptoms. You have 3 choices on what you can do about this. Option 1, do nothing. Put up with it, try not to think about it. Now, most people, by the time they come to see me, they've already tried option 1 and they're not interested in that anymore. And if the patient has so much discomfort, pain, numbness, tingling that it's interfering with their quality of life, or that they have weakness, I usually won't recommend option 1. That's usually not a good idea in that case. So most people, by the time they see me, option 1 not really on the table. Option 2 is basically anything but surgery. And that includes things like pain medicine, muscle relaxers, anti-inflammatories like Motrin, ibuprofen, Advil, Aleve, physical therapy, traction, stretching exercises, chiropractic, pain management with injections like steroid injections, restriction of activities, practicing good neck ergonomics, wearing a neck collar. And all of these things are considered conservative therapies, which basically means anything but surgery. Of all of those therapies, the most invasive is the injection because that involves needles in your neck. All of these therapies that are considered non-surgical conservative therapies, however, don't technically fix anything. If you have a bone spur pinching the nerve, it's not going to make the bone spur smaller. If you have a herniated disc pinching a nerve, it's not going to take away that piece of herniated disc. These options in conservative options are basically Band-Aids or symptomatic treatment. And it's not a bad idea to try these options first to see if you're going to get it better anyway. And keep in mind that even though these options don't take away the bone spur or the herniated disc or unpinch the nerve, just keep in mind that when that nerve is initially pinched, it usually gets swollen, it usually gets inflamed. Now there's even less room for that nerve in there, so it gets even more swollen and inflamed and creates this kind of vicious cycle. So in the immediate phase of the injury, or what we call the acute phase of the injury, the nerve is pretty swollen and upset. If by chance you can get that nerve to calm down, either through medications or decreased activity, that nerve can kind of shrink up, and that bone spur that's been there all along all of a sudden is not pinching that nerve enough to make it unhappy. Or that herniated disc that's squeezed out, it can contract or get scarred down or migrate to a spot where the nerve is not pinched. There are possibilities for that herniated disc to stop pinching the nerve too. Typically, if this is going to happen, and if you're going to get lucky in this respect, we're talking 2 weeks minimum, 6 weeks maximum. So if you're not better by 6 weeks, statistically speaking, you're not going to get better with all of those conservative therapy options. And if that happens, that's when you'll probably get sent to someone like me for consideration of surgical options. So now let's talk a little bit about that. What are the surgery options for this problem? Okay, so to fix the pinched nerve in the neck problem with surgery, there are basically two options, from the front or from the back. I guess before the 1950s, from the back was usually the only way that this was done. The approach through the front, which is called an ACDF, or anterior cervical decompression and fusion, or anterior cervical discectomy and fusion, that's been around since about the 50s. Both of these methods are effective, but I have a preference for one versus the other. For example, if there's a bone spur pinching the nerve in your neck and that bone spur is coming from the vertebral body, which is in the front of the spinal cord, it's going to be pretty hard to get to that from the back without the nerve or the spinal cord being in the way. You're going to see the nerve and the spinal cord before you can see the bone spur. So to remove that bone spur, you may have to manipulate the nerve or the spinal cord, and you don't want to do that if you don't have to. So if a bone spur coming from the bones in the front, it might be better to go from the front to do that surgery because you're going to be able to remove that bone spur before you even get to the spinal cord or the nerve. So that would be ideal. If the pinched nerve is coming from a herniated disc, same situation. That piece of disc is going to be coming from the front of the spine, not the back. So if you try and get rid of that from the back, you may have to manipulate the nerve or the spinal cord. Now, sometimes a herniated disc can be very soft and sponge-like. I kind of liken the disc material to something like crab meat. It's kind of soft but fibrous. Sometimes it's very appropriate to go after a disc herniation from the back because you can tell or you know it's going to be pretty soft, and it also may be far off to the side, or what we call lateral, which means that you can get to it and unpinch the nerve without manipulating the spinal cord. So there are situations where it might be very appropriate to go after a pinched nerve from the back of the neck. Now that's called a posterior cervical laminectomy or laminotomy. I would just say that the surgery from the back is more painful than the surgery from the front, and that's because you have to cut through muscle to get from the approach from the back, whereas from the front you have to kind of go between muscles. And it's the trauma to the muscles that typically causes the most surgical pain. So from a painful surgery experience, the surgery from the back is much more painful than the surgery from the front. What we'll see next is the back side of the spinal cord, the edge of the spinal cord, and then the nerve heading off out the hole, going down to the arm here. But you'll just see this little space here. And this is all done with a microscope, looking through the microscope. So everything's magnified. And you'll see the bottom edge of the nerve running along here, and you kind of gently lift the nerve up, and right underneath that spot you'll typically find either a bone spur or the herniated disc you're trying to get rid of. Unpinch the nerve, make sure it feels free, wash everything out, and then sew all this back up. And that is basically the posterior cervical cervical decompression to unpinch that nerve. A little more painful than the surgery from the front. Overall recovery time about the same. And the downside of that particular surgery is the nerve and the spinal cord appear in your line of sight before the actual pathology or problem. So it potentially means manipulation of those structures, the spinal cord or the nerves, which could put them at risk. But the upside of the surgery from the back is that you don't have to mess with any of the discs. And you don't necessarily have to do any kind of fusion surgery where the bones don't move around, where you make the bones fuse together and they don't move around anymore. So Some pros and cons. My overall preference is I always like to go after these problems from the front. In addition to getting to the problem before the spinal cord or the nerves, the other reason I like going from the front is because often the problem that led to the bone spur forming or the problem that led to the piece of disc herniating out is a bad disc, a shock absorber in between two bones that just isn't working very well. So a lot of patients who have pinched nerves in their neck have had neck pain for many years before that. And a lot of that neck pain, statistically speaking, is coming from that particular bad disc. Because the disc isn't working very well, the bones are rubbing around too much. That leads to the bone spurs growing. That leads to the ligament that keeps the disc material inside getting brittle and getting cracks in it, and eventually letting pieces of disc come out. So by going from the front, not only can you get rid of the problem pinching the nerve, but you can get rid of the bad disc that caused all that trouble in the first place. Put a little bone plug in between the two bones where the disc used to be, and then lock those two bones together with a little titanium plate so that over time those two bones grow together solid and don't move anymore. And that surgery through the front is called an ACDF, as I mentioned before, anterior cervical decompression and fusion. Not only will it make the nerve feel better because it's not pinched, but it'll stop whatever neck pain the patient was having because that shock absorber was rubbing around too much. Because of the fusion parts of the surgery, those bones don't rub around anymore. The signal for the muscles to tighten up back there goes away, and the patient's report not only does their arm feel better, but the old neck pain that they used to have is a lot better. So let's take a look at that a little bit with some diagrams and some x-rays to show what that fusion surgery looks like. So what we're looking at here are some diagrams of the initial stages of the ACDF surgery. Real quick, this is the back of the neck. So this would be the incision for an approach coming from the back of the neck instead of the front. This is a bit long for a single level decompression. I'd say it'd be about half the size for just a one level decompression. But let's take a look at this picture on the left. This is the incision that we typically use for an ACDF. I like the transverse kind of incision here because when it heals, it tends to look better aesthetically. It often can be put in line with a crease in the neck. So this would be what the incision looks like on the patient. And then this would be kind of what you do to get in between the muscle groups going down to the front of the spine. So this is the vertebral body or the bone of the spine in the neck. There's the spinal cord. This is the back of the spine. And you can see these muscle groups being split apart instead of traumatized by going through them. The trachea and the esophagus will be medial or towards the center. The internal carotid artery and jugular vein would be laterally or to the side of the approach. So the surgeon's finger can use to kind of dissect in between these tissues until you can actually feel the front of the vertebral body right here. And then what we'll see on the next picture is the retractors that are put in to keep this passageway open. So let's go on to that next picture. Okay, so here we've got the next step in the surgery process for an ACDF, anterior cervical decompression and fusion. So the incision is made, the dissection through the muscles and other tissues are made, and here you can see the bone, the front part of the vertebral body with the disc above it. These retractors then go in. There are different types of retractors you can use, but this pretty much looks like what I typically would use. And that keeps that space open. And then here on this diagram, you can see the retractors. Here they have a top and bottom retractor. I don't usually need to use those. But here you can see the disc is being removed. You use a scalpel to cut a rectangle in the ligament covering the disc, then you use various material or instruments to remove the material inside the disc. And basically you clean that space out until it's nothing but bone and then bone. All the cartilage is scraped out, all the disc material is scraped out. And then if you look on this type of picture, which is kind of, again, the down the tube type picture, I would be coming from this direction, from the front. There'd be a hole in the ligament here so that I could get access to this disc. And this now enables me to pull this disc material towards me without touching the spinal cord or before seeing the spinal cord. So it's a way to remove a disc herniation without having to manipulate the spinal cord because I've come from the front, not the back. In addition, if they're bone spurs here, you can kind of bite away with a special instrument called a kerrison rongeur, to remove these bone spurs. You can stick little probes out the holes here to make sure that they feel nice and free and that these nerves as they head out are not being pinched. And all this can be done from that space that you create here. Keep in mind, this is typically done using a microscope or some sort of magnification so that you are able to get a real close-up look at all this material so that you can make sure it's pulled away from the spinal cord, pulled away from the nerves. So now everything's unpinched. If the patient had spinal cord symptoms or nerve symptoms, they would feel better. But now there's an empty space in between these two bones. There's a spot that used to be a disc that is now empty. What happens next? Let's take a look at the next picture. So the next step in the process is what to do with that empty space. Well, there are lots of options. One of the options that I like to use is something called a peak cage. It's a material made of something called polyethylethyl ketone. It's a plastic type of material that has a little bit of give to it, similar to the elasticity of bone itself. But you can see there's a hole in the middle of it. I usually stuff that with some bone marrow from the patient's hip area, and I don't mean the hip joint, but the iliac crest, which is kind of where you put your hands on your hips when you rest your hands on your hips. You could stuff this with some material that is sort of off the shelf. There are various types of materials that can be used to put in here to promote bone growth. You can see the little zigzag ridges here that allow you to tap that spacer in, but it would make it tough for it to come out. You can see these little markers here, which have little pieces of metal in them that can show up on an x-ray, so you know where the spacer is on an x-ray. And basically, these come in different sizes, and you pick the size that will prop these two bones apart like they're supposed to be when you have a healthy disc. So the spacer will be tapped into this disc space, and you want it to be under a little bit of pressure because pressure helps encourage bones to grow together. And then the ultimate goal is to get these two bones to grow together into a solid block of bone. So there's no more disc in between them. It's just a solid block of bone. And a good way to get bones to grow together fast is to keep them still. That's why if you break your arm, you break your leg, they put it in a cast. The way you keep these two bones still in the neck is with a little titanium plate and little screws. And that's basically like putting these two bones in a cast. You technically only need that plate for about a year because that's how long it takes these bones to grow together solid. At that point, you don't need the plate anymore, but you don't go back in and take it out. It just kind of sits there and doesn't do anything after about a year. And these plates also come in different configurations. There's plates that are a single column of metal instead of four, with two screws instead of four like this. There's certain spacers that have the screws and the plate incorporated into them, so they all go in at one point. But the way I would do the surgery is I put my plug in first, either a peak cage or a piece of cadaver bone, followed by a separate plate. And that would be what the final step in this surgery would be. After that, after the plate goes on, you wash everything out, inspect everything to make sure there's no bleeding, and then sew up all the layers and eventually the skin. Now let's take a look at what this surgery will look like on some x-rays after the surgery. So finally, we have some x-ray pictures of what this looks like after the surgery. This is a front-back type x-ray. This is a side x-ray. And again, you can see the plate with the four screws. It's harder to see the bone plug in here. But on the side view, you can see the plate, the four screws, and here you can see what looks like a pretty good fusion. So this picture was probably taken about a year after the surgery. You can see the markers in the spacer that was put in, but this is what a solid fusion looks like. So before putting in the spacer, the nerves were unpinched, the spinal cord was unpinched, then the spacer was put in, then the plate and the screws were put in. At this point, as I said, you technically don't need the plate and the screws, but you don't go in and take it out unless there's a reason to. For example, needing to operate on this level, or if for some reason a screw came loose or broke or was causing problems with swallowing or something like that. But anyway, this is what an x-ray looks like after an ACDF surgery. Okay, so you've had the surgery either from the front or the back. Let's just say we did the one from the front. What happens next? Well, the surgery itself typically takes, I'd say, about an hour and a half, maybe 2 hours. You'd wake up in the recovery room. Your throat's going to be a little sore. It's going to hurt a little bit to swallow, but overall not very painful. I usually put a soft collar around my patient's neck for the first 24 hours. You spend about 45 minutes in the recovery room letting the anesthesia wear off. Once you've recovered, you'd go up to a regular room, and I usually keep my patients in the hospital one night. First night, just take it easy. You're allowed out of bed to go to the bathroom, but that's about it. The next day, we'll take the soft collar off. I'll be in around lunchtime, check your incision, make sure your speech is good, you can swallow okay, you're walking with the therapist okay. And typically my patients will tell me, my throat's a little sore, it hurts a little bit to swallow, but boy, does my arm feel better. Some patients will describe a little bit of muscle spasm in the center of their back that they may not have had before. And typically I'll tell the patients that's because your bones used to be very close together. I've now stretched them apart to where they're supposed to be, and I put in a spacer where that bad disc was. And now your joints are stretched a little bit because of that, and that fools your brain into thinking that there's some irritation down there, and your brain will tighten up the muscles in between your shoulder blades for about a week or two. Not everybody gets that, but if they do, it typically lasts about a week or two. If everything looks good, I'll let you go home. 3 or 4 days stuck in the house, that doesn't mean lie in bed all day, but just stay home. You're allowed up and down steps, watch TV, read a book, take a nap, stare out the window, watch the grass grow. A week after the surgery, you can drive, short trips only, the bank, the post office, the grocery store, that kind of thing. But for 2 weeks, I basically want you to be a slug. If you ignore my instructions and are not a slug and you do things you shouldn't do, it's not going to ruin anything I did during the surgery, but it may take you longer to feel better, especially with that muscle spasm in between the shoulder blades. At 2 weeks, if everything looks good, you'll be back in my office for a 2-week checkup. We'll get an x-ray. I'll make sure the bones look lined up, the plate and the screws look good, make sure your incision looks good, ask you how you're feeling. Typically, patients will tell me at 2 weeks, the arm feels great, the pain is gone, the numbness and tingling is almost gone. Typically, the numbness and tingling will kind of work its way down the arm. So if you had a lot of numbness and tingling in the arm from the pinched nerve, by 2 weeks, typically just the fingertips may still be numb. And then by the next visit, which is 4 to 6 weeks later, that will usually be gone. The shoulder blade muscle spasm should be gone, if not very close to being gone. And the patients usually at this point are complaining that they can't go back to the gym or they can't go jogging with their kids or dogs or whatever. But I usually say that's okay, it's a good sign you feel that way. But now that it's been 2 weeks after the surgery, you can now start to slowly add your activities back over the next 4 to 6 weeks, starting with the small stuff, working your way back up to the big stuff. Short answer is by 6-8 weeks after the surgery, you want to go hang gliding or skydiving, you can, but it's going to be a slow, gradual process. The other thing I'll tell my patients is I'd want them to avoid Motrin products and nicotine for a year after the surgery. Nicotine and Motrin has been shown, or nicotine and Motrin products has been shown to slow down the success rate of the bones growing together. So Tylenol's okay, prescription stuff is okay, but none of those Motrin type products or nicotine. And I mentioned that if they do take those things and the fusion fails, it means not only do we have to go back in and redo everything, but the risks will be higher to go back and redo everything. When I see them back for that second visit, if the x-rays look good and they look good, from my perspective, they've graduated, they're off the hook, they don't have to come back. Last thing to talk about are the risks of the surgery, and there are 3 risks for any kind of surgery. It doesn't matter what kind of surgery it is, same 3 risks. Infection, bleeding, problems with anesthesia. All very low, but they're in the book, so we have to tell you about those risks. And that's why before the surgery, we get blood tests, EKGs, chest x-ray, make sure your heart, your lungs, your kidneys, everything works properly, and your your electrolytes are good, and your blood clots properly. Basically make sure you're healthy enough for the surgery. Risk of infection, very low, especially for this kind of surgery. I usually will give patients antibiotics before the surgery, and if they stay overnight in the hospital, antibiotics after the surgery. And this is through the IV. We do the surgery in a sterile operating room. Even though we do all those things, there's still about a 2% risk nationally of surgical infection. Typically, if that happens, it's a superficial infection in the incision, and you just give antibiotics for a couple of weeks and that goes away. There are a couple of risks that are special to this surgery because it's spine surgery and spine surgery in the neck. One risk is injury to the spinal cord or the nerves. You're working near those things, there's a risk you could hurt them. Knock on wood, I've never hurt anybody's spinal cord or nerves before, but those risks are in the books, so again, we have to tell you about them. And that's why everybody for that 1 or 2 hours is my father, mother, brother, sister kind of thing. Everyone gets the same treatment. And that's why it's important that you trust your surgeon and that your surgeon has experience with this kind of surgery and that you basically feel good about the surgery. There are other special risks to this surgery because of where it is in the body. One risk is injury to the esophagus. When you go between these muscles in the neck and go down deeper, the trachea and the esophagus are in there, and you kind of push them to one side or the other and protect them with retractors. It's very important that when you're using the instruments to do this surgery, that those structures are shielded from your instruments by the retractors. So it's very important that your surgeon practices good surgical technique for this kind of surgery. Injury to the esophagus can be a very serious complication from this kind of surgery, but extremely, extremely rare, but we have to tell you about it. And then a final risk is something called spinal fluid leak. The covering of the nerves not only keeps in the nerves, it keeps in spinal fluid. If you get a tear in that covering, the fluid can leak out and give you headaches. Typically, if that happens, you see it right away during the surgery. You can put a patch on it, you can glue it. Extremely low chance of that risk for this particular kind of surgery. And if you are going through the front, it's a bit harder to fix, but they are fixable problems. Again, extremely low risk, but we have to tell you about them. And that's the other special risk to this kind of surgery. So we talked about the problem, why it happens, the symptoms you can get, what the problem looks like on diagrams, what it looks like on the models, what it looks like on MRIs and CAT scans. We talked about the options for this problem other than surgery, as well as the surgical option for this and what to expect before, during, and after this surgery, as well as the risks. So that's probably enough for this to just kind of tide you over until you see your surgeon. Hopefully this will kind of make you feel like you're not kind of deer in the headlights with this problem, and also make you feel like you shouldn't be too scared about this issue. It's a very common problem, and the solutions to fix this are a very common solution that many, many surgeons do every day on thousands of people every year. So this is not an insurmountable problem that you can't overcome. So I hope that was helpful. I hope it answered a lot of your questions. I hope it wasn't too long. But again, thank you for watching the Yourgotodoc YouTube channel. If you think this material is helpful, please like, please subscribe, please give a thumbs up. Please tell your friends about it. And don't forget the most important thing to do, and that is stay healthy.